Hello everyone. So today we're going to discuss COPD risk assessment, severity and management. So what comes to your mind whenever you heard COPD? Well, in COPD, the main underlying cause is a chronic cigarette smoking that affects the large airways or the small airways, and any changes in the large airways causes a chronic cough. Okay, any changes in the large airways causes a chronic cough and excessive production of sputum. Excessive production of sputum. Okay, while alteration or changes in the small airways are responsible for a physiological alteration. Anyway, COPD is an umbrella term for emphysema, and chronic bronchitis. Chronic bronchitis. So it's an umbrella term of these two diseases. Uh, well, for emphysema, it's characterized by a destruction of lung alveoli and with air space enlargement and permanent dilatation. While chronic bronchitis is clinically defined as a condition with chronic cough and phlegm. So anyway, in a nutshell, the chronic obstructive pulmonary disease is defined as disease state characterized by a persistent respiratory symptoms and airflow limitation that is not fully reversible. Okay, so mind you, asthma is an obstructive pulmonary disease. Okay, where there's a limitation of airflow. However, asthma is an inflammatory disease whereby there's an inflammatory in the airways, and there is and it's a reversible. The condition is reversible. For example, if you give a short-acting beta agonist to a patient with asthma, then there is improvement in the FEV1. The FEV1 is okay, FEV1, the forced expiratory volume. So there will be improvement in FEV1 by 12% or 200 ml. However, contrary to asthma, the COPD, there is no reversibility. It's not reversible. So it is irreversible. Okay, irreversible permanent destruction of the alveoli and the large airways, and therefore there is no improvement in the FEV1. Okay, that's one way to differentiate asthma from COPD. The classic definition of COPD requires the presence of chronic airflow obstruction determined by spirometry. Okay, so we can only determine COPD with spirometry. Okay, so this brings us to this table, which is the gold criteria for severity of airflow obstruction. GOLD is abbreviated as Global Initiative for Chronic Obstructive Lung Disease, and it categorizes COPD into severity stages. So it categorizes COPD into 4 stages: stage 1, stage 2, stage 3, and stage 4. Stage 1 is a mild COPD, and stage 2 is a moderate COPD, stage 3 is severe COPD, and stage 4 is severe. It's very severe. So in COPD, regardless of the severity, whether mild, moderate, severe, or very severe, the forced expiratory volume in 1 second over FVC okay, FVC is always less than 0.7. So as you see here, all is less than 0.7. However, this differs in the FEV1. In mild COPD, the FEV1 is equal to or greater than 80% of the predicted, while in moderate COPD, the FEV1 is greater than or equal to 50 but less than 80%. In severe COPD, the FEV1 is equal to or greater than 30% but less than 50% of the predicted. And very severe COPD, the FEV1 is less than 30% predicted. So it's very important that we have in mind in this gold criteria. Okay. This table is very important, and it shows the exacerbation history and the severity of the symptoms. Based on the severity of the symptoms and exacerbation history, it puts patients into 4 different groups, A, B, C, D, which we will discuss further in details. So here we have the exacerbation history, and exacerbation history is based on yearly or annually. Okay, so if the patient had exacerbation, if he had a 0 or 1 exacerbation without hospital admission, that means it's a low risk. However, if patient have at least 1 exacerbation with hospital admission, or in total 2 exacerbation, then that's high risk. Okay, because there's a hospital admission and there is more than 2 exacerbation. On the other hand, we have this the mMRC. mMRC, okay, it is abbreviated as Modified Medical Research Council Dyspnea Scale. So it measures the degree of breathlessness or difficulty of breathing, and it's a 4-item questionnaire which assesses your severity of symptoms. Okay, so these are the 4 items. So if you have breathlessness only with strenuous exercise, then it is 0. If you have breathlessness while hurrying on a level ground or walking up a slight hill, then that's 1. If you have if you walk slower than your peers or stop walking at their own pace, then that's 2. And if you walk about 100 yards or after few minutes on level ground because of breathlessness, that's 3. If you are too breathless to leave the house, or you feel breathlessness when resting, then that's 4. So CAT, mMRC and CAT is also similar COPD assessment test. It's a 8-item questionnaire which has a score of 0 to 40. So if you have less than 10, that means you have low symptoms. If you have greater than 10, you have high symptoms. So you can use either one, mMRC or CAT. Okay, so now if you have mMRC of 0 to 1 of these symptoms, then you have a low symptom. But since you have 0 or 1 without hospital admission, then that is low symptom and low risk. On group C, if you have mMRC of 0 to 1 or a CAT less than 10, that means you have a low symptom. But here you have at least 1 exacerbation with hospital admission, or in total of 2, that means high risk. So low symptom, high risk. In group B, mMRC of more than 2 or CAT more than 10, that means high symptoms. Okay, however, you have 0 or 1 exacerbation without hospital admission, that is low risk. While in group D, you have mMRC greater than 2 or a CAT greater than 10, that means high symptom. So but here you have more than 1 exacerbation with hospital admission or greater than 2 or in total of 2 exacerbation, that's already high risk. So based on the symptom severity and exacerbation history in the past year, a patient can be placed into these groups, either group A, B, C, or D1, and the management is tailored according to each group. So this one will have a management, this one will have a management, and this one will have its management, and this group as well have its management. So now let us go to the management. So group A will have just a simple bronchodilator, okay? And once we give the bronchodilator, we evaluate the effect of the bronchodilator, and we continue, stop or try alternative class of bronchodilator. For group C, we give a long-acting muscarinic antagonist, LAMA, okay, LAMA, or and if there is further exacerbation, then we give a combination of LAMA plus LABA, LAMA plus LABA. Okay, in group B, we give a long-acting bronchodilator, either LABA or LAMA, one of it. Okay, if the symptoms persist, we give a combination of LAMA plus LABA. Okay, so for group D, which has high symptoms and high risk, we first give LAMA, and if there is further exacerbation, we give a combination of LAMA plus LABA, and if there is further exacerbation, then we switch the medication. We give either LABA with ICS or LAMA with inhaled corticosteroids. Okay, if there is further exacerbation, then we give a combination of LAMA plus LABA plus inhaled corticosteroids, a combination of 3. If there is a further exacerbation, then we consider roflumilast if the FEV1 is less than 50% predicted and patient has chronic bronchitis. If symptoms still persist, okay, and there is further exacerbation, then we consider adding macrolide, especially in patients with smokers. So that is it. The medication is LAMA. Examples of long-acting muscarinic antagonists are tiotropium, glycopyrrolate, or aclidram. Those are the long-acting muscarinic antagonists that are mostly used. We have a short-acting muscarinic antagonist, which is ipratropium, which is used to relieve symptoms. Okay? While the LABA medication or the long-acting beta agonists are formoterol, salmeterol. This is a quick revision of your pharmacology. So formoterol, indacaterol, oladeterol, okay, oladeterol,